It's day 2 here at TCT in Washington, D.C., and I'm Peter Block for On the Scene. One of the major issues that plagues interventional cardiologists like me is what do you do about the patient in atrial fibrillation who needs additional double antiplatelet therapy? And with me is Nicholas Sarafoff from the Herzzentrum Clinic in München, Germany. So Nicholas, tell me about your trial.
Well, the optimal duration of triple therapy in patients with atrial fibrillation or receiving stents is unknown. So we randomized these patients to a short triple therapy consisting of 6 weeks clopidogrel in the setting of aspirin plus a vitamin K antagonist versus 6 months of triple therapy with aspirin, clopidogrel, and vitamin K antagonists. And what we found was that the primary endpoint, cardiac death, MI, stent thrombosis, stroke, or major bleeding, was not superior in patients with 6 weeks as compared to 6 months triple therapy.
So you randomized 6 months against 6 weeks, obviously worried about the fact whether or not bleeding would be an issue and so forth. I mean, all of us worry about bleeding with triple therapy plus anticoagulation. Tell me about what you used for anticoagulation.
We used vitamin K antagonists, warfarin or fenprocomone in the study because at the time we designed the study, these were the only agents available.
So you did not use any of the new oral anticoagulants?
No, these were not part of the protocol.
Okay. And at the bottom line, you said that there was no difference in the two. So give me a short version of what you think this trial tells people who are caring for people in atrial fibrillation who need a stent.
I think it's important to note that while we had no increase in ischemic events with the shorter duration of triple therapy, we also had no increase in major bleedings with the longer duration of triple therapy. So this reassures some of us who would rather give a shorter duration of triple therapy in patients with a low risk for thrombotic events, and on the other hand reassures those who would think of a longer therapy in patients with a high thrombotic risk because TME major bleeding was not significantly higher in this group.
So you think the risk of thrombosis still plays a little bit of a part as what you would choose for your patients?
Of course it does. So it depends on the stent placement and whether it's a stent with a high thrombotic risk or not.
Thank you very much, Nicholas. So there you have the answer to that question, or at least a short one, and that is it doesn't make any difference, 6 weeks or 6 months, outcomes about the same, though you still have to worry about what the thrombotic risk is for your patient.